Now I'd like to give the floor to Professor Baisov. And, you know, as has already been told, the possibilities of surgery are exhausted. And now we need to look for new approaches. And probably our future success will be mostly associated with the medicines and medicinal therapy. Thank you very much for presentation. I would like to start my presentation and go into history for a short period of time. How can we get back to the beginning? And let us speak. And also we will speak about modern approaches to treatment of pancreatic cancer. Pancreatic cancer is a huge problem for radiologists, for therapists, but not for surgeons. There are very few patients who can be subjected to operative treatment. If we look at the statistics of 2008, we will see that we have 458 new cases of cancer, and you see how many people died. So 94% died of pancreatic cancer. These are American data of 2016. 5-year survival amounted to 7.7%. And the number of new cases of pancreatic cancer is increasing with every year. Mortality from pancreatic cancer is higher in Russia than survival. And it is connected, of course, with the post-operative diagnostics. This is the prognosed mortality of pancreatic cancer in the USA. If we look at what was in 2010 and what will happen in 2030, with the constant growth of incidence, by 2030, 70,000 patients with pancreatic cancer will die by 2030, 2 times more than in 2010. As to the problems of treatment, this is the lowest line, so we do not see any results for a long period of time. We failed to reach any results. The progress in treatment of cancer is very, very modest. A 5-year survival is below 5%. Of course, surgery, the beginning of surgery was very important in Whipple surgery was performed on many patients, but this surgery in itself is not the best option for treating pancreatic cancer. 5-year survival after surgery is only 10%, and the chemotherapy and medicinal therapy help to raise this 5-year survival. With adjuvant therapy, the median of survival was 25% last year. Now, how can we help our surgeons, we therapists? This slide shows the history of therapeutic treatment. It has started with SPAC1, where there were 3 groups. And the best results were from the Mayo regime as an adjuvant therapy. Then there was CONCA trial that showed that gemcitabine is very effective. And then SPAC3 that showed that gemcitabine is comparable by its result, has the same shows the same survival or ensures the same survival. FUFA, and the last jump was the SPAC4 that showed that the combination of GEM-CAP provides the best advantages compared with monotherapy by gemcitabine. So we may see that the combined chemotherapy improved the results of treatment. There was a very interesting Japanese trial, JASPAC-01. The survival was really striking. So the combined therapy showed a 5-year survival of 43.6%, so almost 2 times higher than monotherapy by gemcitabine, and the toxicity was quite low. And the last trial of 2018, this is the use of combination of FOLFIRINOX compared with gemcitabine. So the primary and secondary endpoints were achieved. And here you see the results that a median disease-free survival was 21.6% in case of combined therapy. The overall survival was also high, 63.4% using FOLFIRINOX. The overall survival median was 54 months. The use of adjuvant, the advantage of adjuvant therapy was demonstrated in all groups for any stage T and N pre any status of resection edges, regardless of the resection volume. However, there was quite expressed toxicity for FOLFIRINOX regime. And despite the fact that only preserved patients were included, the toxicity was very high. So diarrhea was observed in 84.4% of cases. That's why, speaking about adjuvant therapy, we may say that we can use gemcitabine and capecitabine, combination of gemcitabine plus capecitabine, and FOLFIRINOX regime. As to S1, we don't have data on the European population. That's why we may say that that modified FOLFIRINOX is the best standard of adjuvant chemotherapy for patients with ECOG 01 without surgical complications. And without any comorbidities, and these patients must be below 70. And only one patient could endure this neoadjuvant therapy of FOLFIRINOX. Anyway, the doctor has a choice to use any combination. But the chemotherapy is to be started 4-8 weeks after the surgery. As to colon cancer, for example, if it is chemotherapy starts 3 months after 3 weeks after the operation, it is too late and it doesn't give any result. So the dates are very important, and the chemotherapy is to be started right after surgery. What are the disadvantages of post-operative adjuvant therapy? Most patients die. A 5-year survival is a bit over 20%. GEM-CAP give it 29% survival. And after surgery, not all patients recover rapidly, and that's why adjuvant therapy cannot be used for all patients who underwent a surgery. Over 20% are not eligible for adjuvant therapy. And there are no satisfactory current data for R2 resection. I would like to say one more thing related to pathologists. Most people here are surgeons. But I would like you to pay pathologist attention to it. By the results of a SPAC-04 trial where GEM-CAP was used as an adjuvant treatment, for the definition of negative edges of resection, they used Royal College Oncology classification. They studied the presence of cells not on the border, but at 1-2 millimeters difference. And it was shown that if we take a larger depth of the margin, the possibility of defining R1 resection increased many times. What are the problems to be solved to improve the results? First of all, we need to improve the results of patients with poor prognosis. In case of stage 3 of the disease, we need to affect the early micrometastasis and increase the frequency of R0 resections. And as SPAC-4, in a SPAC-4, when they took RCP criteria to define the resection edges, the frequency of resection was 60%. Neoadjuvant or perioperative therapy, localized border-like cancer. First of all, rationality. Virtually 100% of patients can be treated. Their state is much better. It may increase the possibility of RO resection, and it may simplify the surgery. And of course, an additional bonus is that we have very many tissue to understand microbiology. Since it's the trial of phase 2 GEM-CAP, so here we see patients with locally advanced pancreatic cancer. So here you see the purpose of the trial and how the trial was going on. So 107 patients were included, 61 completed the stage of induction, and even fewer patients continued treatment, only 46 patients, and at 16 patients were operated. What can we see? Again, this is a locally advanced process. there was no full regression. So 30% of patients had partial regression. But we managed to control the disease, which was a very good indicator. And 38% of patients showed the decrease of the tumor diameter by more than 30% after 2 cycles of chemotherapy. And 12 patients completed trial, and they were offered another chemotherapy. 17 patients got radiotherapy, and 16 patients were operated. Well, quite a good time before continuation of treatment, 10 months before progression. So this trial showed that in this cancer, the median of TTF amounted to 8.8 months, and the survival was higher than for stomach gut cancer, gastric cancer, that had a different chemotherapy. So we may see that this disease, pancreatic cancer, is much more serious, but the use of adequate chemotherapy allowed to get a 1-year survival of 72% of patients. 30% of patients showed an objective response. This is one of the first trials, first phase 1. And now let us speak about the trials that will help us reconsider the approach to the treatment of gastric cancer. The trial is called PREA-PANG, and it studied pre-operational chemical therapy. So the bordering tumors amounted to 63% in different groups. So here you see X-ray criteria that were developed by the American Association. And here you see the data of the operation and the pre-operational chemotherapy. At the first stage, patients could be operated, but it, of course, depended very much on the skill of the surgeon that undertakes the operation. But it would have required reconstruction of large vessels. As a result of chemotherapy, we managed to make operations for 60% of patients, resections, and the frequency of resections was 72%. RO resection amounted to 31% on the first stage, and for pre-operational chemotherapy, 63%. As to serious adverse events, they were the same in all groups. It was also noted that the disease-free survival is shown here. So the time before remote metastasis and recurrence take place, the patients who received the chemotherapy showed much better results. It should be also noted then, analyzing those patients who were just operated, the difference was of 13 months in favor of preoperative chemical therapy. One more trial from South Korea, where gemcitabine was used with chemotherapy before the operation, then 4 courses of chemotherapy, then chemical radiotherapy, and 4 courses of gemcitabine. The 2-year survival in case of neoadjuvant approach was 40%, and for adjuvant approach 26%. The median of TTP was 2 times higher for patients with pre-operational treatment. And also for patients who received pre-operational therapy, the RO resection level was much higher. This is the trial PACT-15 of phase 2 and 3, efficacy and safety of pre- and post-operational chemotherapy of resectable pancreatic cancer. And this trial is underway, but preliminary data show that the groups that received pre-operative treatment showed much higher results compared with those patients who began treatment from surgery. As to induction therapy, as patients with bordering operable tumors, we have 2 trials of the 3rd phase that shows what is used as a chemotherapy on the neoadjuvant stage, and it leads to the increase of overall survival. And so for patients with border resectable tumors, it has become a standard therapy. But we don't know what is the advantage for resectable cancer, what is the level of risk of making chemical radiotherapy, whether it is necessary to drain hepatic ducts, and we are looking forward to other trials about up-to-date regimes, FOLFIRINOX and others. A few words about what we're doing in our clinic. We have had quite an experience in using chemical radiotherapy as a starting phase. We make both operable and non-operable patients, and we can classify them, but in fact we take all. As to the results of treatment, when we make 6 cycles of FOLFIRINOX, then we either make a surgery or use a radiotherapy. A number of patients, about 20 people from 70 we operated on, and on different stages of treatment.
But let me put it like this. I was much more satisfied with the other results, that those patients who were not operated but who were treated conservatively, the ones who had FOLFIRINOX and later with capecitabine that was stereotactic, and I emphasize that stereotactic radiotherapy. So for 5 days they got about 4 degrees. So these patients, the median of survival for this category of patient is longer than 20 months. So data is comparable with the surgical median of survival. Well, definitely these data require further confirmation, and we need to extend the pool, patient pool, but we believe that this is quite promising information which allows us somehow look more optimistically at the role of chemotherapy in the treatment of pancreas. What is also interesting, just 2-3 days ago, I faced Korean article on prognostic factors based upon all these analyses that was shown in Korean study. What really influences patient survival, the ones who get neoadjuvant chemotherapy. So they identify several aspects. First, this is reduction or normalization of markers C99 post-op. After neoadjuvant stage, this is a correction of the speaker. Then second influencing factor is not less than 6 cycles. So they were pooled results of any chemotherapy, gemcitabine with nab-paclitaxel, FOLFIRINOX, not less than 6 cycles, not less than 6 cycles of treatment. This is also an independent prognostic factor, which influences the results of treatment. And so this is the last study I would like to draw your attention to. This is PrEP-02 JSEP-05 randomized phase 2-3 study of pre-op chemotherapy GS-S1 plus gemcitabine. So that it was presented by Oscar GI by Andrew Zhu and colleagues. So where they actually treated initially resectable patients who were stratified depending on the level of C99 and institutions. So some patients got surgery and adjuvant S1, and the other group got neoadjuvant GS plus surgery plus adjuvant S1. And the primary endpoint, as you can appreciate here, was overall survival in P3, resection rate in P2. And this is how the design of the study looked like. The primary endpoint at phase 2, because that was phase 2-3, so the primary endpoint was the resection rate of the patient. It appeared to be the ones that got NAC-GC neoadjuvant option. 93% of resection rate versus upfront surgery, 82% only. And as a result of phase 2, they moved to phase 3, and here you see the baseline data, demographic data of the patients accrued, and actually looking the same, very comparable, no differences. Here you can appreciate how many patients were enrolled into each group, so eligible about 180 to each group at particular stage. Some people did not receive NAC, or 7 withdrew, or didn't start NAC, or there were distant metastases found, or did not receive the surgery. So different drop-offs, and finally 172 were treated in NAC-GS group, and 178 were treated in upfront surgery group. As you see, finally, 32 were not resected in the first, and 49 were not resected in the latter. And finally, from both groups, from all those that were eligible, finally 140 were resected for curative purposes, and 129 were resected for curative purposes in upfront surgery group. So this is the data that was presented at Gastrointestinal Cancer Symposium in 2019 by Miyaki Uno from the Hokuto University. And here you see different drop-offs, the ones who were not operated, not resected, or in 11, for example, in the left group, they found some cytology positive cells, that means dissemination during the surgery. 2 of them did not have PDAC, and 3 had distant lymph node metastasis. Well, so all in all, 140 were resected, and in the upfront surgery group, they resected 129. So this is toxicity of the regimen. Yes, it is high. It is high, and it is high due to the fact that this is also an Asian population of patients. Speaking about overall survival, it appeared to be better in all the subgroups, and for neoadjuvant chemotherapy for NAC group, it was about 36.7 months, and for upfront surgery it was 26.6 months, and 2-year overall survival was 10% higher in favor of neoadjuvant, perioperative, I would call it, perioperative. What also should be reported, neoadjuvant regimen allowed to reduce the lymph node metastasis rates. The progression of the disease, progression rate, we have to say that using chemotherapy at stage 1, stage 2, perioperative chemotherapy versus adjuvant chemotherapy. So you see much rarer progression was reported due to distant metastasis, specifically liver metastasis. So this study showed clear advantages of overall survival using NACGS, and overall survival median was 36 versus 26, and mortality risk was reduced by 28%. Also, there was dramatic reduction of lymph nodes involvement, 60% versus 81%, and, well, not bad tolerability of NACGS. But still, questions and limitations of the study, although the result is obviously positive, but still, this is interpretation which requires some cautiousness. First, this is just Asian population. There were differences in intensity and durations of chemotherapy, so these patients who got neoadjuvant chemotherapy, in fact, got more intensive treatment, and also it was added with adjuvant option. So this study does not say what sort of treatment patients received after the relapse. So it also carries particular limitations of the study. They did not explain the influence of R1 resection, and they did not provide the results of time to progression. So because of that, this study causes particular questions, so this is one of the weaknesses. So what are the specificities of neoadjuvant therapy? And this is what I want to draw your attention to. So you should not assess neoadjuvant therapy according to standard criteria. So RESIST is not applicable here. No, we need special criteria. So that means neoadjuvant therapy. So the most important is to reach R0. So we should assess resectability. We should free the vessels, and it should not increase post-op mortality. Criticism towards neoadjuvant therapy was already provided by all the surgeons, that we create, let's say, artificial selection of the patient. But I hear such complaints continuously from abdominal surgeons when we are speaking about the gastric cancer treatment. So why we need neoadjuvant? They say, we will manage without it, and adjuvant will help us, blah, blah, blah. But nevertheless, we just came back from the Gastric Congress. The whole world is using neoadjuvant, so there is nothing to argue about. Everything has already been proved. And I'm pretty sure the same happens with pancreatic cancers in the near future. By the way, I would like to emphasize once again, in pancreatic cancers, we have initially, primarily disseminated process. So formally speaking, I think 90% of radically resected patients are not cured, So in principle, let's say the role, the accent should be done towards combined options of treatment. Again, questions: which is optimal treatment? Chemotherapy, chemoradiotherapy, chemotherapy with further chemoradiotherapy, which regimens, and what are our final objectives? So all that is in the stage of design and identification. What is the most important? Overall survival, or zero resection rate, resist objective response, or pathological reaction. So, and well, I liked one of the presentations on the circulating DNA in gastric cancers. For example, number of American researchers offered to assess the results of adjuvant treatment at different stages by circulating tumor DNA in blood. So the radicality of the surgery and the radicality of adjuvant treatment is to be assessed by this parameter, but not by the life expectancy or life duration, which may be influenced by a number of other parameters. Well, this is expensive tool, but this is very promising and interesting idea. Well, here, whether neoadjuvant chemotherapy may resolve these problems, it can improve overall survival and to increase R0 rate and to influence early micrometastasis rate. So I think that should be our starting point. I have an impression that if we do it just formally, so what you called either borderline resectable or unresectable tumor, unfortunately, we will not get much from that, because anyway, for one doctor, the tumor would seem completely resectable, for the other one completely unresectable, and we will never standardize. I think everybody should be treated with neoadjuvant. What could be the conclusions? So post-op, adjuvant is already standard. Neoadjuvant and peri-operation surgery may reduce to the surgical rates in patients with aggressive disease and reduction of R1, and gives hope to improve long-standing results and can get additional information for understanding of the disease. And once again, everything is good, but our way is very long and thorny. Thank you very much.